Good morning, I'm Leo from PKUHAC, and I'm pretty glad to be here to make this talk show. My case is about ICH, intracerebral hemorrhage. So my talk show is to begin with a case of Mr. George, a 40-year-old handyman with a past medical history significant for hypertension, presented to the emergency department with sudden-onset right hemiparesis. He did not take antibiotic medications. His initial BP was 184/93. The neurologic exam was notable for speechless, lateral gaze deviation, and right hemiplasia. He got 14 in the Glasgow Coma scale, 19 in the Stroke scale, and his ICH scores 0. His CT showed the left putamental ICH. Obviously, Mr. George was getting into a trouble of ICH. So what is an ICH? ICH is intracerebral hemorrhage, defined by the sudden onset of focal neurologic deficit caused by hemorrhage into or around the brain. Okay, let's take a look at a sketch about the process of a putamental ICH caused by chronic hypertension. As the chronic hypertension goes on, a microaneurysm formed in the parenchymal arch of brain, and as shown, the lenticular straight vessels are most commonly involved, with similar processes may occur in other parts of brain. Once the microaneurysm ruptures, it will cause pressure on vessels beside it. That is how the satellite microaneurysms happen, and they also rupture later. So here the blood comes out of the microaneurysms and pushes the surrounding tissue to the other side and even flows into the ventricle. You still can find a scar of a huge hemorrhage on the right side. ICH is the end result of chronic damage to cerebral small arteries and arterioles caused by a number of risk factors. Among patients older than age 55 years, who account for the majority of cases, chronic hypertension, cerebral amyloid angiopathy, and chronic use of antithrombotic medications are the leading risk factors for primary ICH. ICH could be catastrophic if untreated in due course. So both in the pre-hospital and ED management, you gotta do something to find a better outcome of the patient as possible as you can. The primary objective is to provide airway management, provide cardiovascular support, and transport the patient to the closest facility prepared to care for patients with acute stroke. In the ED, you will need to take a medical history of the patient, complete a physical examination, lab examination, as well as an ECG to make a feasible evaluation. Scoring tools can provide a more specific measure, and it usually could be a good predictor of outcome. A CT scan, as the gold standard, can be a very sensitive way to identify acute hemorrhage with a spot sign based on CTA to identify patients at high risk of ICH expansion. This is George's CT image, and it shows the left putamental ICH with no intraventricular hemorrhage and minimal local mass effect, which is suggesting a typical hypertensive putamental ICH. These images show an expansion of ventricular extension 24 hours after a right chordal hemorrhage, and the sports side on baseline CTA, he already predicted an ongoing bleeding. Generally, an ICH patient will get a headache, nausea, vomiting, and depressed level of consciousness. Neurologic deficits usually vary by the location of the hemorrhage. Different types of hemorrhage can result in different features, and there will be a progression over periods of hours. In a medical therapy for an ICH patient, you gotta pay attention to his hypertension, hematoma expansion, intracranial pressure, and seizures. Elevated BP is very common in acute ICH and is associated with great hematoma expansion and neurological deterioration after ICH. So to have patients' BP well controlled often means a better outcome for them. The two most studied hemostatic agents for use in spontaneous ICH are elevated recombinant human factor 7 and tranexamic acid. But actually, they are only used in the context of a clinical trial because of unproven benefit. Besides, for patients who develop an ICH, all anticoagulant and antiplatelet drugs should be discontinued acutely after the onset of hemorrhage, and anticoagulant effect should be reversed immediately with appropriate agents. Increased intracranial pressure due to ICH can result from the hematoma itself and from mass effects due to surrounding edema or hydrocephalus, and may contribute to brain injury and neurologic deterioration. Basic measures outlined here should be instituted initially for all patients with ICH. The reported risk of seizures in patients with acute spontaneous ICH is approximately 15%, but the prophylactic medication is not recommended. Continuous EEG monitoring could be at hand, and if seizure occurs, appropriate intravenous anti-seizure drug treatment should be administered to prevent current seizures. For patients whose cerebellar hemorrhage is larger than 3 cm in the company of brain stem edema or hydrocephalus, a surgical therapy should be on the agenda, including a standard craniotomy when lobar clot is greater than 30 ml within 1 cm of the cerebral cortex. Okay, so my case ends here. Before the end of the talk show, I'd like to share another case that once happened to one who is working in the ED. Sometimes it could be quite tricky that you have to make a decision at the very moment that you haven't yet figured out what is really going on with your patient, right? So in this case, what would you do? You always be welcome to share your idea with me and friends right here. And thank you so much for your attention, and I hope you like my talk show. If I got something wrong, just please don't hesitate to let me know so that I can make a correction. Thank you again. Bye.